basically an old adage, and we've proven the fact that it is wrong to do triple H. We don't do all those three H's. We don't do hypertension, hypervolemia, and hemodilution. We do a little bit of hypertension, but as I said, the new term is hemodynamic augmentation, meaning the cardiac index is actually at least as important as the MAP, if not more. The other old thing that you're going to hear is, oh, well, at least get the CVP on my subarachnoid patient or on my ischemic stroke patient so that I know if he's hypovolemic or volume depleted, at least I will know that I can guide myself with a marker, which is the CVP. That is also an old fashioned way of treating patients, and that has been proven in critical care to be wrong, to follow the CVP to guide as the sole marker your fluid management. Another thing that maybe you will hear is, at least please keep them tanked up, meaning euvolemic or the upper edge of the Starling curve, or slightly hypervolemic. That is actually not true either. There's a lot of publications that have proven that actually the more fluids we give them, we give to subarachnoid patients, and the more the functional outcome is altered. So don't keep them tanked up. But yeah, you should not be starting from very far behind, so you need to pay attention to your Frank Starling curve, but you don't need to make them necessarily at the edge of hypervolemia. These are the publications proving what I'm telling you, that CVP is useless, that triple H is useless, but maybe only induced hypertension works well, and that hypervolemia is not ameliorating even their hypertension effects onto brain perfusion. That paper also was basically sending the right message about starting to focus on the stroke volume variation instead of the CVP. That is pretty old, I think, already, but I don't see the date here. But I think about 10 years ago, or around 2009, we published that from Columbia. Like, we looked into the CVP as compared to the SVP, and what was correlating better to the prediction of subsequent cardiac output. And sure enough, the SVP was significantly correlating to the subsequent cardiac output, as opposed to the CVP was performing atrociously. So, I mean, it's like flipping a coin, as you can see. So the SVP is not only correlating to the subsequent cardiac output of your patient, but if you measure the oxygen in the brain parenchyma of your patient after a subarachnoid hemorrhage, you will see that actually the SVP predicts really well that a bolus will result in not only a higher cardiac index, but also a higher level of oxygen in the brain. So basically, we should not look at only cardiac index as the new marker of fluid responsiveness, but fluid responsiveness, and that's what I've been trying to promote at the Society of Critical Care Medicine, should be basically defined on the amelioration of the end organ perfusion. And I know in the ER, for instance, you use the lactate trending, and you see the clearance, and the faster you clear the lactate, probably the better you perfuse all the organs. But in the brain, at least, we can look at the markers like microdialysis or the PPTO2 or the neurological exam. If your patient is suddenly better after a bolus of fluids or an amelioration of their cardiac index, you know that indeed you ameliorated the end perfusion. So we should not even look at the cardiac index as the end for all, whatever the expression is in English, meaning the end point really that tells you everything. It should be actually the end organ perfusion. So the Frank Starling curve, I hope you're familiar with it, and of course all those publications about SVB and PPV are based on that, the fact that if your preload is compromised, you will see a lot of variation, because during the respiration, the venous return will ameliorate your blood pressure, and then the patient will expire, or exhale, sorry. The patient will exhale and have less venous return, and in mechanical ventilation, it's reversed. During the inspiration, the positive pressure will drop your blood pressure and your pulse pressure, versus during the inspiration, the negative pressure of your mechanical ventilation will lead to a higher venous return, and therefore the blood pressure and the cardiac index will be ameliorated. Those variations are very big when your preload is low, and of course it's completely attenuated when your preload is high. So fluid or volume responsiveness is based on that concept, that the variation of your pulse or your MAP will be very mild when you give more fluids, as opposed to the variation will be really high for the same volume of increase in the global end diastolic volume, when your patient is underfilled in terms of his venous compartment. However, remember that once you're at that level, also, the more you're going to give more and more and more fluids to your patients, you will not see any fluid responsiveness anymore. There won't be any amelioration of the cardiac index, but you're starting to be in a dangerous zone because now you're going to give too much fluids, and that does not get captured by the SVV. So even last week I was running in the CQ and I was a little bit taken aback by the statement of one of my colleagues that was saying, well, anyway, just do your SVV, we'll do the flow track, and we'll keep bolusing the patient, and don't worry, once we know that the patient is not fluid responsive anymore, we know that we've avoided giving too much water and he's not going to develop pulmonary edema. And I explained the fact that that is not true. Actually, the fluid responsiveness will plateau and be almost negative, so the SVV will be very little, but you could continue to give, unfortunately, fluids and continue to harm your patient. So you never know when you're starting to induce pulmonary edema. That's extravascular lung water. So what are the methods to assess fluid responsiveness? And I'm paying a lot of, many slides on fluid responsiveness. That's almost the majority of the talk, because I feel like if we're not doing the correct thing and we're giving too much fluids or starting pressors too early on our patients, we're not going to ameliorate their brain function. So it's worth spending enough time hopefully educating you again. I'm sure maybe some of your other teachers have taught you about fluid responsiveness, but I think it's really critical before starting pressors and looking at the brain function. So how do we assess for fluid responsiveness? The passive leg raise is one option. When you raise the legs and you drop the head, basically, of course, all the 300 cc's or 250 cc's of veins, of blood in your veins in your calves will be coming back down to your IVC, and there will be basically a temporary infusion of 250 cc's of volume. The pulse contour analysis is also really great because we don't need to stimulate the patient, because the drawback of that, and they don't talk too much about that, all those gurus about fluid management, because they talk about septic patients in the ER or in the ICUs that are usually mechanically ventilated and sedated. Unfortunately, our neuro patients, we try not to sedate them as much as possible because we try to get a Glasgow Coma scale every 1 hour. And in my experience, I am a little bit disappointed by the value of passive leg raise in neurocritical care, because unfortunately when I stimulate the patient by even gently dropping their head down and lifting their legs up, it stimulates them. Suddenly I'm rousing them from their sleep, and then sure enough, just the tachycardia results in a higher cardiac index. So that doesn't mean they're fluid responsive, that just means that I stimulated them and I rose them from sleep. So I like to use also those other methods, which are pulse contour analysis. It's supposed to be during a normally breathing patients, or even better, there's a better accuracy when you do a mechanically ventilated and sedated patient. The respiratory variations, if you have at least 8 to 10 cc's per kilo, will result in a pulse variation, and that a pulse pressure variation can tell you if your patient is fluid responsive or not. The other techniques are thermodilutional, but we don't have that here. Do you have that in the ER? The PICO machine, which shoots a little bit of cold saline, and it does the circulation time, and it can calculate how much global and diastolic volume you have and how much extravascular lung water you have. So that is actually giving a little bit of extra information as opposed to the flow track or VGLEO, which is the pulse contour analysis methods that you have. There's other ways of testing also, and I'm sure you're more familiar with this one. So you can grab your echo and or ultrasound basically, and do your IVC distanceability or your SVC changes, and that will tell you if your patient is fluid responsive or not. So I really want to actually, and that is why I'm sorry I copy-pasted exactly the wording, because I think the exact terminology that is written in that article is really what needs to be taught more precisely. So basically, Paul Marek and others have been really trying to change over the last 20 years the fluid management in critical care in America and in Europe. And basically that paper is really limpidly putting some concepts that need to be well grasped. So basically, fundamentally, the only reason to give any patient a fluid challenge is to increase their stroke volume. If this does not happen, the fluid administration serves no useful purpose and is likely to be harmful. Furthermore, the increase in stroke volume, and thus the cardiac output, must be judged to be beneficial, and that's something I highlighted because a cardiac index increase of 20% or 10%, which was the original definition of fluid responsiveness, doesn't necessarily mean anything about perfusing your kidneys better. Is this really going to result in a better urinary output? Is this going to result in a better Glasgow coma scale in my patient? I'm not so sure. So maybe we should put the bar higher for what we truly mean as end organ perfusion amelioration, and sometimes a cardiac index going up only 10 or 15% is not even sufficient. We need to go even higher to see an improvement. So remember that even fluid responsive patients may not actually be judged to be benefiting from continuing to plumb them up. Fluid loading per se is not always the correct therapy for hypotension or even a reduced urinary production. Fluid therapy acts by increasing the stress volume of the blood that you have in your veins, thereby increasing the venous return to the heart, and as the venous system has much greater capacity than for blood compared to the arteries, it is a normal physiologic condition to be fluid responder. So that's the other thing. Then in neurocritical care in 2009, there was a paper that said, oh, I'm more fancy, I use fluid responsiveness. I use IVC distensibility, and I do flow track, and I do the Getty out of my PICO, and I guide my fluid management. There was a paper from Tokyo about subarachnoid patients should be on PICO, and a Getty less than 800, you should bolus them with more fluids. That is ridiculous. Number one, the Getty is not a fluid responsiveness rate marker, the global and diastolic index. Number two, if you think that all fluid responders should receive fluids, for you in the ER, you're going to give fluids to 90% of your patients. Everybody's fluid responsive. It's a physiological thing. So what you need to guide yourself is, am I unhappy with my cardiac index and my MAP? If I want to ameliorate that, do I want to give a bolus of fluids and go up on norepinephrine? Then you can use the fluid responsiveness, and indeed in those fluid responsive patients, you should start by giving them a bolus of fluids rather than ramping up their MAP. But saying all fluid responders with brain ischemia or septic shock should naturally get fluids is a little bit of a leap, and that is well explained right there. So not all patients who are fluid responsive necessarily require a volume expansion. That is another paper also in critical care saying the same thing. A lot of attention has been paid to assessment of fluid responsiveness, but there is a lack of studies evaluating the indications truly for fluid treatment. So fluid responsiveness or volume responsiveness does not equal you have to give a bolus to this patient. Avoiding harm with the use of fluids requires understanding of what is physiologically possible also. So continuing with Marek, he's also saying that indeed we should also decide how much volume. So we're saying fluid responsiveness. Should we give 250 cc's of NS or 500 cc's or a liter? Should it be NS, LR, colloid, packed red blood cells? That's another discussion, and I'm sure you're familiar with the literature that has addressed that too. It may be beneficial to allow some patients to be actually a little bit fluid responsiveness, and look at that statement. That's actually, that has been criticized. He's even saying, even for septic patients, Paul Marek is not a neurointensivist, he's talking about septic shock in the ER. It is not necessarily true that we should always put our patients at the edge of their Frank-Starling curve on the right side. He's just saying you should try to ameliorate it, but being at the edge sometimes will push them into pulmonary edema. So you don't have to be at the edge and eradicate your fluid responsiveness and abate your SVV below 12%. That is not a true statement. You need to be more nuanced than that. So if you have to remember only one number, the SVV above 13% has been shown to be predictive of a cardiac index amelioration when you give a bolus of 250 cc's, but that a cardiac index amelioration, as we said earlier, does not necessarily mean that your patient will be better perfused in terms of their end organ function. Marek has been saying don't use the CVP for now 20 years, and he's saying please use the fasting leg raise or a fluid challenge. That is the best. And indeed, when you go to those lectures that he gives internationally, that was in 2013 in the Netherlands, or in Belgium, he was basically saying Please don't use the CVP that's in red. Please don't use the IVC diameter. Please don't use the LV and the Getty and all those things to guide your fluid management. What you really need to know if your patient is fluid responsive, you should use the passive leg raise or a volume challenge. And in orange is putting some acceptable options, which are the IVC distanceability, the PPV, the SVV, the PVI, and if you have a do you have a for your intubated patient, do you have a transesophageal echo that can give you continuously the aortic flow? So aortic blood flow also has been done in ICUs, usually in CT ICUs, to measure continuously what is the aortic blood flow. Then you have it. You have a very direct measurement of your cardiac index. So that is a decent way of assessing fluid responsiveness. If you want to do some literature search, please look at all those big names in fluid management. I'm telling you, they are really excellent at telling you what to do for your patient in the ED or in the ICU. This is the same basically, the CVP is crap, and this is decent, and this is the best according to all those meta-analyses looking at the review, the quality of prediction with the accuracy of fluid responsiveness. With the caveat, I told you that in neurocritical care, I don't like that because they jump as soon as I touch them. Even tactile stimulation, I don't jump to pinching them. But even tactile stimulation raised the cardiac index of all my patients, so I'm a little bit perplexed by that, and or disappointed by the passive leg raise. And a rapid fluid challenge, yeah, that's good, but now you give your fluid to your patient, so you cannot remove that. That's the beauty of the passive leg raise. When you put them back down, the fluid is removed. So I tried to integrate that in the course that I gave at the Neurocritical Care Society using ultrasound. The same way you do it in the ER, you use the IVC distanceability to look for volume responsiveness. And basically, I'm sure you're familiar with that. You need to be a little bit at distance from your right atrium, and you look on the M mode for the variation of your IVC distanceability during a spontaneous breathing or in a mechanically ventilated patient with at least 8 to 10 cc's per kilo. And you will see the variation. You see the diameter max and the minimum diameter, and then you can do the distanceability, which is the difference divided by the minimum. So here you have a distanceability of 136%. There's other ways of looking at the same, basically. The distanceability can be transformed into also a delta, which is not only not the difference divided by the mean, but the difference divided by the average. Or you can look at your IVC contractility index with compressibility index, which is the difference divided by the max instead of divided by the minimum. So all those three ways of looking at the variation of your IVC basically has been proven to have a very good positive predictive value and negative predictive value for volume responsiveness. Now, I know in the emergency medicine literature, there's actually a lot of publications that have said all those fancy things, we don't need all that. Actually, we just do an IVC diameter, and if we, with our own eyes, we're not super fancy, just 1 month of training of doing echoes in the ER. And again, I'm not bashing on you. I do the same. I'm not a fancy ultrasonologist, but if you see that your IVC is completely collapsing, you don't need all those calculations. And there was one publication that said that they compared all those fancy indexes to visual collapse of the IVC during an IVC distanceability checking by a poorly trained emergency medicine physician, and that sufficed. So I think we can use either or. If you want to be more advanced and be more evidence-based, you can use that, but if you want to be quick and dirty, you can do it because you have some publications that support that suffices. One caveat is that basically people keep saying that you cannot do it in spontaneously breathing patients. Well, we're not going to intubate just for that reason. So actually there's a lot of publications in the ER about doing it in non-mechanically ventilated patients. So it's not ludicrous to do it as an outpatient or in the ED in a spontaneously breathing patient. The other caveat that they always put in those meta-analyses is you need to have positive pressure ventilation with a tidal volume that is 8 to 10 cc's. However, actually it's maybe too much. However, dropping it down to 6 cc's per kilo on every patient in order to prevent ARDS is a little bit of a stretch. It is true in the other ICUs, but in neurocritical care, it is not necessarily true. That's an editorial that I wrote in neurocritical care in 2014. Of course, you need to have a sinus rhythm. That is the definite. Yeah, if you're arrhythmic, you cannot look at your pulse pressure variation or SVV because your heart is not pumping regularly. So of course your venous return will be one beat great, the next beat poor, the next beat great, the next beat poor. So there will be a lot of variation. And the last point is for the higher PEEP, of course it modifies the value, so you need to make sure that not only your tidal volume is adequate, but your PEEP is not super high, otherwise you're going to have alterations in your numbers. What I was really compelled to see was the IVC Distance is also changing upon the therapy. I like all the publications that shows that IVC Distance predicts fluid responsiveness. I like the fact that there's IVC Distance correlation to the subsequent fluid bolus ameliorating the cardiac index, but the other way around too. When you give furosemide, you're making it worse. So I think it is really, really compelling, all the literature using IVC Distance as a great marker of your fluid responsiveness. Let's keep that. So that is in neurocritical care. We started using it, I think, in 2010. In Italy, they used the IVC Distance to guide their fluid management in subarachnoid patients. But remember, what matters more is actually the oxygen amelioration in the brain. So now let's go to the topic of exactly hypertension, the way we do it. Is there even data that hypertension without hypervolemia ameliorates the patient? So in subarachnoid patients, they have ischemia when they are in vasospasm. Yes, hypertension without hypervolemia works alone. And when you compare hypervolemia plus the hypertension, does the hypervolemia at least add a little bit to the hypertension? And the answer is no. So there's really no value in doing hypervolemia in those patients. When you look at up-to-date and you look at hemodynamic augmentation for delayed ischemic neurological deficit, that's what maybe you guys call a clinical vasospasm. So yes, it works, but look, those trials have been basically not randomized clinical trials, but basically a few cohorts of patients that were studied, and there was an amelioration in terms of their clinical exam. You can use phenylephrine, norepinephrine, or dopamine, and in a stepwise fashion, you will see an amelioration of their clinical deficits. You can use dobutamine or milrinone too, because it makes more sense that we're focusing more on the cardiac index, and milrinone also has the beauty, the added beauty of maybe dilating the vessels in the brain. So when you do cardiac index and MAP increase, which is what we call hemodynamic augmentation, do we have also non-clinical surrogate endpoints that we can use? Here are the evidence for the clinical endpoints, and here are the evidence for the non-clinical endpoints. Meaning, what if I measure the brain oxygen non-invasively by near-infrared spectroscopy? Yes, the cardiac index, when you raise it up with the cardiac output, it ameliorates the level of oxygen in the brain. That is also another publication in subarachnoid patients. If you look at other things like the clinical exam, and in conjunction with the cerebral blood flow, there is amelioration when you induce hypertension in vasospasm patients. Cerebral blood flow is ameliorated only in the ischemic regions. That's interesting. So you see, maybe actually I'm going to press my patient in vasospasm and actually ameliorate them only in the area that need it. And I'm hopefully not inducing edema or too much perfusion or luxury perfusion in the other areas of the brain that don't need it. So there seems to be a Robin Hood phenomenon. The cerebral blood flow is also increased when you use induced hypertension with phenylephrine in that paper. And finally, cerebral blood flow as well as the clinical exam, as well as infarctions in the brain, were all ameliorated when, less clinical exam deficits, less infarctions, and more cerebral blood flow when you do the Triple H therapy. Yeah, that was in the 90s when they were still doing Triple H. Dobutamine, though, is not the panacea, because then people were telling me, well, if you're pushing for cardiac index to be the new MAP in neurocritical care, then we should use dobutamine in all our patients. The problem, though, and I've used it a couple times, is unfortunately it triggers a lot of arrhythmias, and even in normal-looking hearts of a 20-year-old, you can induce some severe arrhythmias or even an MI. So, or Takotsubo cardiomyopathy. So don't jump onto dobutamine saying, oh, that is so much better. Dr. Kapinos told us not to focus on phenylephrine and the MAP anymore. Dobutamine can prevent, though, delayed ischemic neurological deficit, but I was really disappointed by this French paper that had the complete wrong endpoint. They said, we're going to use dobutamine not to reverse the clinical exam, but to reverse vasospasm. Of course, it didn't work. I mean, that makes no sense. Why would dobutamine amelioration of the cardiac index make your vessels bigger in your brain? So of course, milrinone is better for that because it ameliorates the cardiac index, but it also directly dilates, most likely, the capillaries in your brain. Induced hypertension now for acute ischemic stroke, while I'm sure Dr. Law and Dr. Bell will be covering more of that this morning. But I wanted to give you a few papers supporting that it works. Basically, inducing hypertension can ameliorate the patient's clinical exam. So if they have a large occlusion, an M1, and they have a significant aphasia and right-sided drift, you can ramp up their blood pressure, and in front of you, they will ameliorate their clinical exam. So that was only the first case report that I saw in 2006. Then there was another case report of one patient in 2009. And then there's animal models that show that when you induce hypertension, the infarction will be smaller. But is there really a study in humans? Then I got excited to see Raldorf at MGH was doing it in 2001. That was a pilot study. And then you'll see another slide. They ran the trial, but I think nothing got published to support actually the effect of induced hypertension in ischemic stroke. There's also those two other papers that say that it's feasible and it's safe, so those are basically pilot studies. But when you go to the actual publications, nothing really showed in a large randomized clinical trial that it ameliorates the functional outcome of our patients. So Vedic wrote also a review on that, and he's basically saying that sure, we can ameliorate the cerebral blood flow, but it's not ready for prime time because there's unfortunately a lot of risk of worsening the brain edema and the ICH. So what it tells me is not that it doesn't work. It probably works, but we need to select our patients a little bit better. What if I measure their blood-brain barrier in order to prevent their brain edema and their hemorrhage? I think those patients with a large ischemic stroke that have no alterations of their blood-brain barrier, then we can induce hypertension really high or cardiac index augmentation and salvage them without that risk of bleeding or brain edema. So those three trials, Rordorf, Koenig, and Hillis and Marzan, unfortunately I found them in literature as preliminary results, but I don't know where the trials went. I need to call them at MGH, and now he's in Hawaii, and those guys, I don't know them, but I don't know where their trials went because it never got published that a randomized clinical trial showed that inducing hypertension in ischemic stroke ameliorated the functional outcome. So in conclusion, I just want to parallel what I learned from all those big names in critical care and emergency medicine in America and Europe. By the way, if you want to go every year, it's during Thanksgiving, unfortunately, so Americans never go, but in Belgium, they have a wonderful Fluid Academy Day when they tell you how to do fluid management. And it's fun, and there's all those big names are going, and they will tell you what is their new paradigm and what are their institutional practices using all those new methods. So, for instance, even 10 years ago, they were saying in the ER, we start to use the lactic clearance to guide how much fluids we're giving, and we stop as soon as the lactate starts to plummet. Some others were saying, no, I prefer to look at the urinary output. In a septic shock patient, I bolus them until the urinary output goes back above X. So what I've done is basically transposing their talks and their algorithms into what matters in neurocritical care. So first, you need to document your hypoperfusion. So in septic shock, the blood pressure is low and the urinary output is extremely low. So for me, it's hypoperfusion in the brain. The patient is having an acute ischemic stroke or a spinal cord injury, and it's within 48 hours because after that, I don't think there is significant brain ischemia anymore. But who knows? Sometimes we're surprised. Sometimes it lasts one entire week. Anyway, just to be precise, at least during the acute phase of an ischemic stroke, if you have a subarachnoid hemorrhage and you have mu neurological deficits, Or if you do an MRI and you can see little punctate ischemic lesions, or you do a CT perfusion and you see a perfusion deficit, or you do quantitative EEG and you see ischemia, or you measure the oxygen in the brain and it's low, or you measure the cerebral blood flow and it's low. So you need to document your hypoperfusion. Unfortunately, the brain is not as simple as the kidneys with the urinary output. The Glasgow Coma Scale is not that great, so we need to use a little bit more precise markers of ischemia. Once you've documented your ischemia, okay, now I need to ameliorate the perfusion of my brain. How do I do that? I need to attain a certain goal of cardiac index and MAP. I put some numbers here, but everybody disagrees about those. They're really pulled out of thin air. But 2.5 is usually mild hemodynamic augmentation, 3 is considered moderate, and probably the maximum that I've seen in publications is 4 of the cardiac index. And those MAP numbers are extrapolated from the septic shock world. 65, spinal cord injury, people say 85 is better. And finally in vasospasm, some people have said a MAP above 120 is useful. So you can grade that. So how do you achieve that? That's when you wonder, is my patient fluid responsive in order to achieve these numbers? So you can use your PPV or your SVV, you can use your IVC distensibility, your passive leg raise, or your fluid bolus. But don't jump to every single patient that has that number should give fluids. No, only ischemic patients that are not at the goal that I have in mind to ameliorate their brain perfusion, that are fluid responsive, those are the patients that I'm going to give fluid. If they are not fluid responsive, then I need to unfortunately go to pressors, and norepinephrine is favored over phenylephrine. Or you can use dobutamine, or in vasospasm you can use milrinone. How much fluid should you give? That is what I learned from Monet and all those other guys. They were saying, we don't like when the neurointensivists are using the Getty to guide your fluid responsiveness, but we like to use the Getty to tell us how much fluids we're going to use. So use your SVV to know if your patient is fluid responsive, and use your global and diastolic index to know how much fluid you should give. If your patient is so behind, his Getty is so low, indeed 500 cc's or even maybe a liter should be considered, versus the patients when they are not so hypovolemic, maybe a smaller bolus of 250 cc's, if they are fluid responsive according to the SVV, would ameliorate the cardiac index. And then the next question is, am I at risk of pulmonary or subcutaneous edema? And as I said, don't use your SVV. It's not because you normalize your SVV that, oh, now I'm fine, I'm going to slow down and I'm going to avoid pulmonary edema. They're saying during those conferences that you should in parallel know if you're giving too much fluid to your patients and you are at risk of pulmonary edema or subcutaneous edema. So that is why they like to use the PICO machine, because that thermodilutional catheter gives you a Getty and also an LV, the extravascular lung water index, and when it's above 10%, you should avoid giving too much fluids because you are at risk of pulmonary edema. But they don't remember also, by the way, they said, we don't use that to start furosemide. It's not because you have an LV of 10% or 20% that you should give furosemide to them. They're saying, we use the clinical exam. We start giving furosemide when you have crackles, or because Paul Mayo has been advocating also for using lung ultrasound with the B-lines, being way more sensitive than the stethoscope and the chest X-ray. Actually, your lung ultrasound with the B-lines should be guiding your diuresis therapy. Which is another question, finally, than the last question that you should ask yourself, which is, when do I stop my diuresis? Do I stop when the B-lines are going away? No, of course not. You stop when your PF ratio is normalized, without altering. I hope you didn't go so far on furosemide on your patient that you unfortunately drop the blood pressure, because if you drop your blood pressure, yeah, now you have to do push and pull, so albumin and furosemide. So that is the last, I think, slide. Basically, prevention of failure is different than fixing the failure in shock. In neurocritical care, please at least use your fluid responsiveness first, then ask yourself, can I use inotropics? Then ask yourself, did I fix the CPP, which is the equivalent of the MAP for septic shock? Did I fix my CPP or my perfusion of my brain? The problem in neurocritical care is the Glasgow Coma Scale is not exactly as precise as the urinary output, and the CPP should at least replace the MAP. Cardiac index is important. And for those who are interested in writing an ISC grant with me, I want to use the quantitative EEG to help myself in guiding the fluid management, meaning the cardiac index ameliorating your clinical exam. Sometimes it takes a few minutes for the patient to reverse their clinical exam. And quantitative EEG is actually early on, within a few seconds, it tells you if your patient is fluid responsive with an amelioration of their alpha power. Or if you guys prefer ultrasound, because you are very well versed on that, we can replace the quantitative EEG with TCDs. I would love to rush to the ER with you every time you have an M1 occlusion or a large ischemic stroke. We put the cap on with TCDs, and you bolus your patient. You see an amelioration in your cardiac index, an amelioration in your map, but the patient has these TCDs with a mean flow velocity that is not ameliorated. Stop. You don't need to raise the blood pressure of that guy because he's not ameliorating his cerebral blood flow. But another patient that has a cardiac index amelioration that results in a mean flow velocity that is ameliorated, here we go, and organ perfusion is ameliorated, that patient you should continue to give fluids until there's no more amelioration. And so I think that will guide our management. Just last slide, embrace neurocritical care. Please consider training with your ENLS so that you know what to do during the first hour of the neurological emergency. Become a member of the Neurocritical Care Society, and I hope the next year we'll have a fellowship here. So if you're doing EM and critical care medicine, only 1 year additional and you can be a neurointensivist. And if you want to go into neurocritical care right after your emergency medicine residency, you can do 2 years with me and be a neurointensivist too. It's really fun. We do a lot of fancy stuff. We use a lot of probes in the brain. We ameliorate the patient's outcome. We don't need to drill in the skull. We can use TCDs. I know you're very well versed on that. We can do a lot of analyses of the odor regulation, etc. It's really a lot of fun. So please consider neurocritical care for your next fellowship.